Good afternoon, dear students. It's time to start our today's lecture. Today we continue studying of Propaedeutics of Internal Medicine in Department of Propaedeutics of Internal Medicine, and now it is cycle of lectures for MM groups. And previous lecture we finished another system, and our today's lecture is about endocrine organ disorders. And unfortunately, according to our schedule and our thematic plan, we have just one lecture in propedeutic cycle about endocrine organ disorders. That's why we include one of the most often and maybe the most danger of endocrine disorders. It is diabetes mellitus. It is a part of my big lecture that consisted of two parts about thyroid organ disorders and diabetes mellitus. All this lecture it was recorded previous year. You can listen in my YouTube channel this recording, a full form of this lecture. And according to our plan, today we have just second part of this lecture that named diabetes mellitus, the main clinical signs and symptoms and diagnostics of diabetes mellitus. And before we start discussing diabetes mellitus, let's remind for ourselves what the function of pancreas. If you remember physiology and pathophysiology, pancreas have as exocrine as endocrine function. Both of these functions included in this organ. And today we discuss, because we have endocrinology lecture, endocrine function of pancreas. Okay, let's remind first of all the what is pancreas consist of. You can see it here in the picture on this slide. Yes, that in pancreas, except of exocrine cells, it is present islets of Langerhans that consist of several types of cells. The most important for us, it is alpha cells and beta cells. Moreover, it consists ducts, delta cells, and it present red blood cells and pancreas acini. Yes, and as I told, the most interested we are in alpha cells and beta cells. And these cells and delta cells, these cells produce different types of hormones. Glucagon produced by alpha cells, insulin produced by beta cells, and somatostatin produced by delta cells. Hormones travel through the bloodstream to target tissue, from the pancreas to all tissues, all organs from the human body. And the target cells hormones being specific receptors and cause cell changes that control metabolism. Yes, the main function of endocrine pancreas, it is controlling of metabolism. And who don't remember, please return to physiology and read how insulin and glucagon, like balancing system, regulate different type of metabolism in our body. It is very important for our today's lecture. Okay, sorry, one moment. Okay, as I told, two main metabolic hormones, it is insulin and glucagon, and their balance, their changes regulate different types of metabolism. Through what processes? Yes, if it insulin function, insulin effects, it is increasing of glucose oxidation, it is increasing of glycogen synthesis, it is increasing of fat synthesis, and increasing of protein synthesis. Yes, it have anabolic function. It accumulates everything, and it stimulates synthesis and accumulation of different types of chemical agents in our organism. And glucagon, it is an opposite hormone that have a little bit opposite effects. With increased glucogenolysis, increase gluconeogenesis and increase ketogenesis. And insulin, glucagon, it is hormones of fed state, it is for insulin, and fasted state, it's for when it is domination of glucagon. And this balance between fed state and fasted state, and balance in organism between insulin and glucagon, regulate our nutrition, our feeding, and balance of all chemicals in our organism and all metabolic processes. Okay, insulin. It is a polypeptide hormone composed of two chains, A and B. Our today's lecture is connected with specifically insulin. Both these chains of insulin A and B are derived from proinsulin. It is pro-hormone, yes, it's something that was before synthesis of hormone. These chains are joined by disulfide bonds. Yes, it is two chains that connected with each other with small chemical bonds that consisted of disulfide. Okay, structure and role of insulin. Acts on tissue to increase uptake of glucose and amino acids. You understand? Increases glucagon production or glucose storage in the liver and muscle. It stimulates lipid synthesis from free fatty acids and triglycerides in adipose tissues. Also, insulin stimulates potassium uptake by cells. It is role in potassium homeostasis. Chemically, it acts based on mechanism chemically in high levels of glucose and amino acids in the blood. Hormonally, beta cells are sensitive to several hormones that may inhibit or cause insulin secretion, both effects in different hormones. It can regulate neurally. Stimulation of parasympathetic nervous system causes insulin to be secreted. Yeah, that's why regulation of insulin synthesis can goes in by chemical mechanism, by hormonal mechanism, and by neural mechanism. Insulin secretion is decreased by decreased glucose and increased insulin concentration in blood and sympathetic stimulation. Insulin transported through the blood to target tissues where it binds to target cell-specific receptors and acts as a biochemical signal to the inside of the cell. Cell metabolism is stimulated in this case. Yes, one more time, why I want to stop and pay more attention to the mechanisms and pathophysiology, because diabetes in general, it is a very big topic. It is even a whole science like diabetology, and not to learn a lot of information, not to learn a lot of moments in diagnostics, in treatment. First of all, you should understand mechanism. If you understand mechanism, if you understand pathophysiology, if you one more time return and remind for yourself what is insulin metabolism, what is glucose metabolism in our organism, what functions of glucagon, what is ketoacidosis, what is lactoacidosis. If you remind and understand for yourself what is that, you will not need to learn a lot. All diagnostics, all symptomatic can be explained by this mechanism. That's why it will be very easy for you to explain all further management of this patient. Okay. we told that insulin secretion regulates by blood glucose levels. And we have a normal range of glucose, and the most usable test for glucose, it is fasting glucose. It when glucose, blood for glucose takes in the morning before breakfast, after at least 8 hours of hunger. Yes, the normal range of fasting glucose is from 3.9 to 5.5 millimoles per liter. We name it normoglycemia. Everything that lower than 3.9, it is hypoglycemia. Everything that higher than 5.5, we can name hyperglycemia. Hyperglycemia can be short-term and persistent. Short-term can be physiological hyperglycemia, for example, after eating something sweet. Yes, when you eat big piece of sweetie pie, after it can be some short time, some episode of physiological hyperglycemia. For health person without diabetes, with normal tolerance to glucose, it is okay, it's not a danger. But short-term hyperglycemia can be pathological too, and most of all, it connected with pre-diabetes. When the level of hyperglycemia during some time stay elevated, we name it persistent hyperglycemia. It can be impaired, that typical for pre-diabetes, and it can be high, that typical first of all for diabetes mellitus. But it can be on endocrinology, you will know that it can be different, other different cases when it can be hyperglycemia but without diabetes mellitus. And hypoglycemia, as I told, it is low levels of glycemia. Okay, first of all, purpose of our today's lecture, it is and purpose of investigation of patient with suspected diabetes mellitus. It is general evaluation of health. It is diagnostic of disease and disorders of endocrine pancreas and diagnosis of other systemic diseases that affect endocrine pancreas. Okay, in disorders of endocrine pancreas, as usual, we started from patients interviewing. What in history taking we are interested in, most of all when you suspect in this patient diabetes mellitus. The main points, it is gathering of information, it is patient's narrative, it is biomedical perspective, psychological perspective, and context. It what I told you on lecture, general lecture, Propaedeutics. First of all, you have to detailize and you have to understand for yourself some main moments. Yes, psychological state of this patient, biomedical perspective, patient's narrative, and other main points, and just after it, detailize medical state of this patient. Okay, clinical monitoring of diabetes and diabetic complications. We should check blood pressure. Yes, if it is hypertension, it is management of hypertension and further monitoring of hypertension and thus risk of further high disease. In a patient with diabetes mellitus, risk of all cardiovascular disorders much more higher than for person without diabetes mellitus. And if you remember classification, it also risk scoring, maybe in hypertension lecture I showed you a scheme of score of cardiovascular risks. And you remember, even if in patient without other risk factors with a normal level of blood pressure present diabetes mellitus, it is automatically classified patient as high risk or very high risk of cardiovascular disorders. That's why you should understand that diabetes is very, very dangerous for this patient. Next target organ that we obligatory exam in diabetic patient, it is eye examination, and with management of different, it can be different eye disorders. The most often of them we name diabetic retinopathy, and monitoring onset and progression of eye disease. And it can be food examination. Yes, one of the often complication of diabetes mellitus we name diabetic food. It is combination of diabetic angiopathy and neuropathy that can lead to damaging to ulcering and even necrosis of lower extremities that we name diabetic foot. Diabetic foot, it is the most important cause of hospitalization, and it is the most often cause of all amputations in people in general, and of course in diabetes mellitus. As I told, it is combination of progression as nerve disease as arterial disease. Indications for testing for diabetes mellitus. Of course, first of all, if it present symptoms, we testing patient for diabetes mellitus. But diabetes, especially type 2 diabetes, if you remember, it can be three main type of diabetes. Type 1, it is diabetes of young people that caused by absolute insulin deficiency, when endocrine pancreas not produce insulin at all. Diabetes mellitus type 2, it when all okay with endocrine pancreas, but it is abnormal sensitivity to insulin. We name it insulin resistance. It can act correctly, and it lead to hyperglycemia and clinic of diabetes mellitus. It is diabetes mellitus type 2, which is nearly 90% of all diabetes cases. And one more type that we often can meet in clinic, it is gestational diabetes. It is hyperglycemia in pregnant women without, what is important, history of diabetes before pregnancy. We name it gestational diabetes. We have much more type of diabetes, but they are more rare. We discuss it a little bit on endocrinology next semester. But for today, just main points in Propaedeutics. And what I want to talk that I told that 90% of all patients, it is diabetes mellitus type 2. What is typical for diabetes mellitus type 2? It is very, very gradual manifestation, and usually patients even with middle and even severe forms of diabetes mellitus during months and even years they don't know about their diabetes, because clinical symptoms are not specific, they are not very bright, and usually they are not present, or if they present, they are such not specific, like some dizziness, some dryness, that patients do not pay attention to it at all. That's why groups of risk, now we discuss what groups have to do checkup, have to do screening for diabetes every year, annually do screening. Okay, according to American Diabetes Association, what groups of people have to obligatory do checkup for diabetes mellitus. First, it is people with obesity. Obesity today on the first place of in risk factor of diabetes mellitus type 2. It is when the BMI more than 25 kilograms per square meter, and especially in obese people with BMI more than 30. It considers testing to detect pre-diabetes mellitus and type 2 diabetes mellitus, even in asymptomatic people. It is obligatory to do in patients with family history of diabetes mellitus in first or second degree relatives. Testing is obligatory for people with signs of insulin resistance or conditions associated with insulin resistance like acanthosis nigricans, hypertension, dyslipidemia, low birth weights. All these people annually have to do checkup for diabetes tests. Patients with maternal history of diabetes mellitus or gestational diabetes mellitus during gestation. If female notes that during gestation, during pregnancy, she had diagnosed gestational diabetes, further with the age, she has much more higher risk of diabetes mellitus type 2. That's why such patients we screening for diabetes 2. Okay, what panel of laboratory tests we usually do for diabetic patients? Yes, as usual, as for all our patients, it is CBC, it is complete blood count. It is glucose, usually serum glucose. It can be most often fasting glucose. What I told you, it is taking of venous or capillary blood in the morning before breakfast after at least 8 hours of hunger after night. Next test, it is oral glucose tolerance test. It is test when we do, first of all, we check fasting glucose. After it, we give patient solution of 70 grams of glucose in water. Patient drink this solution, and in 2 hours we recheck level of glycemia. And according to this level, after glucose tolerant test, it gives us additional diagnostic information. Now we will discuss norms. Okay, it can be random blood glucose. Yes, it's possibly to do glycemia test, not depending on meal and time of test. Yes, and it is important for emergency department, for example. Yes, we can do moreover islet cell antibody test. We use it for diagnosing of diabetes mellitus type 1. When you will read in at home, or maybe somebody remember from pathophysiology that type 1 diabetes, it is autoimmune disorder with autoimmune attack against beta cells. That's why to confirm presence of type 1 diabetes mellitus, we should find islet cell antibodies. One more very important test, it is hemoglobin A1C or glycated hemoglobin. It is a level of hemoglobin including molecules of glucose in percentage to all number of hemoglobin. It is a very important test, and it is very useful for controlling, first of all, compensation, is diabetes compensated or not, and effectiveness of our treatment, because in comparison, for example, with fasting glucose, it is more stable, because fasting glucose can be one day high, one day normal, one day more high, and a lot of factors can influence it. For one spontaneous elevation, it can be lead to sweetie meal in the evening. It can be some inflammation, it can be physical or emotional stress, and a lot of other factors. That's why fasting glucose, it is obligatory test, but just one this test isolatory, it's not a very reliable. That's why for us, for compensation and confirming presence of diabetes, we need more reliable test, and this more reliable test, it is glycated hemoglobin. It shows you situation with glycemia and compensation of this glycemia during 3 months. And additionally to all those tests, we have diabetic urea analysis. Okay, according to World Health Organization, diagnostic criteria for diabetes should be maintained. What criteria, according to those tests, we use to confirm or not confirm diabetes mellitus? First, it is fasting plasma glucose more than 7 millimoles per liter or 126 in milligram per deciliter. If it is oral glucose tolerance test, it is more than 11.1 in millimole per liter or 200 milligrams per deciliter. Fasting glucose or oral glucose tolerance test elevated more than 7 for fasting, more than 11.1 for OGTT. And additionally to those tests, it have to be glycated hemoglobin more than 6.5, and even for today, it more old criteria, I didn't change it. In latest guidelines, the criteria is 6. Everything that higher than 6%, it is criteria of starting or manifestation of diabetes mellitus. And glycated hemoglobin more than 5.7, even if it not reach criteria for diabetes, it says you about pre-diabetes or risk of diabetes mellitus. And here what I told you on previous slide, that glycated hemoglobin reflects average plasma glucose over the previous 2-3 months in a single measure, which can be performed at any time of the day and does not require any special preparation such as fasting. Okay, criteria, diagnostic significance of glucose level and glycated hemoglobin concentration. For non-pregnant individuals with diabetes risk and age more than 45 years and pregnant women with risk factors, when fasting glucose more than 126 in milligram per deciliter or GTT more than 200 and glycated hemoglobin more than 6.5, it is criteria confirming diabetes mellitus. If for this group fasting glucose or GTT, fasting glucose from 100 to 125 or GTT from 140 till 200 and glycated hemoglobin more than 5.7, it is increased risk for diabetes or pre-diabetes. And for all pregnant women from 24 to 28 weeks of gestation, it is period for screening for gestational diabetes, the norms are lower than for other people. For fasting glucose, it is more than criteria for gestational diabetes, more than 29 milligrams per deciliter, and OGTT in first hour 180, second hour 153. If it is higher, it is criteria for gestational diabetes. And diabetic urea analysis, we do simple urinary test, and here obligatory it is diagnostic for ketones. In general, what can be diagnosed in urinalysis? First of all, it is glucose urea. It can be detected when level of blood glucose exceeds more than 11 millimoles per liter. Yes, it is 11 when kidneys start to filtrate glucose from the blood to the urine and can't reabsorb it effectively. Yes, and we find in normal, you know that it don't have to be glucose in urine. In glycemia higher than 11 in diabetic people, glucose urea, you can see glucose urea. Urine test can't be used alone to confirm the diagnosis of diabetes mellitus. They are ordered more often when there is suspicion of type 1 diabetes mellitus because its high specificity for ketoacidosis. Yes, it is very informative to check in for ketoacidosis. And here you see testing by a strip. Patients, people with diabetes, even don't need a laboratory to confirm presence of ketonic bodies or ketones in the urine. They have for it ketone strips or urine test strip. It is a paper strip that can, like a pregnancy test, that put it into the urine, and according to color of indicator we can check is it present ketones or absent, and is by the intensity of color we can understand how much ketones in this moment in patient. The body produces ketones bodies when fat tissue is used for energy instead of blood sugar. If ketone bodies are present in urine, this could indicate the high level of glucose in blood with insufficient level of insulin production. And on this slide it is explanation why ketoacidosis is typical just for type 1 diabetes mellitus. Who don't understand, please return to pathophysiology. For people with diabetes mellitus, you know that diabetes is unreachable disease, and people live with this diagnosis during all their lives. That's why we can't control this patient all the time during life in laboratory. They have to do it individually, and the most usable way for it is using of individual glucose meters. They look like here on this picture. When the patient with a very small needle take a capillary and 1 drop a capillary blood, put it in the paper strip, you put in the device, and device can show you level of capillary glucose in this moment. And more modern way to controlling glycemia level for patient, it is continuous glucose monitors. They look like this. It is not a big device, smaller than smartphone, that consists of electrode that fixed subcutaneously with sensor that can sense level of glycemia. After this, electrode goes to the device, and every 5 minutes it check glycemia, visceral tissue glycemia level. They can build some graphs of level of glycemia. Your patient can check, and doctor can check it by smartphone or even by the watches, and if the level of glucose too high or too low, it gives some signal to the patient to eat or to inject insulin. Okay, let's discuss a little bit about types. Diabetes mellitus type 1, I told you that it results from the body's failure to produce enough insulin. The main risk factor, it is viruses and toxins that can affect genetically determined antigens of HLA system and cause, that I told, autoimmune destruction of beta cells of the islets of Langerhans. And And diabetes mellitus type 2, it is mechanically, by mechanism, it is absolutely other disorder. It begins with insulin resistance, a condition in which all cells of the body fail to respond to insulin properly. All the disease progresses, a lack of insulin may also develop. Yes, further, secondary to insulin resistance, it can added lack of insulin or insulin deficiency. This form was previously referred as non-insulin dependent diabetes mellitus or adult onset diabetes mellitus because most of people have manifestation in older age. The primary cause is excessive body weight and lack of exercise. And third, one of the main forms, it is gestational diabetes. Occurs when pregnant women without previous history of diabetes develop a high blood glucose level. One more time, I talked today several times. The gestational diabetes, it is hyperglycemia without previous history. If we find hyperglycemia and increased OGTT test in pregnant woman, but previously before pregnancy she had diagnosed diabetes mellitus, for example type 1, it's not gestational diabetes. We diagnosed it like further manifestation of diabetes mellitus type 1, and we can put diagnosis gestational diabetes just in case when it was no diabetes previously before the pregnancy. Okay, symptoms, clinical symptoms of diabetes mellitus. They can be classic, non-classic. Classic symptoms is just three. In general, there are four. Three of them started the same, like poly. And we name it like polyphagia, polyuria, and polydipsia. Very polyphagia, it is increased hunger. Polyuria, frequent urination, and polydipsia, increased thirst. Okay, other symptoms, they are less specific, as I told you, but very often in patients with diabetes we can meet it. It is blurred vision, it is fatigue, weight loss, poor wound healing like cuts, scabs, etc. It is dry mouth and dry, itchy skin. Other symptoms, it is impotence in male. It can be recurrent infections such as vaginal ear infection, groin rash, or external ear infection. We usually name it swimmer's ear. We can divide all symptoms or more early and more late. Early symptoms that connected directly with hyperglycemia and more late connected with complications. Early symptoms, it is frequent urination, increased thirst, blurred vision, fatigue, headache. And more later, for type 1 diabetes mellitus, they can be connected with ketoacidosis. It is fruity smelling breath, it's very specific smell from the breathing air. It can be nausea and vomiting. It is shortness of breath, dry mouth, weakness, confusion, coma, and abdominal pain. And persistent hyperglycemia. One more time, schematically I show you symptoms for better remembering of persistent hyperglycemia. Okay, what can we see on picture? It is weight loss typical for type 1 diabetes, but for type 2 it will be opposite, weight gain. It is fourth specific for fourth typical symptom for diabetes mellitus. Additionally to it, for hyperglycemia, it can be extreme tiredness, it is increased hunger, excessive thirst, frequent urination, tingling and numbness, blurred vision, unhealed wound, and for fun, urine attracting ants. Yes, why? Because it's sweetie, it contains a lot of glucose. And another picture schematically for your objective examination when you examine patient system by system, for what you should pay attention. Central system, it is symptoms, it is polydipsia, polyphagia, and more common for type 1 lethargy and stupor due to severe hyperglycemic and ketoacidotic states. In eyes, blurred vision for both types of diabetes typical. In breath, it is smell of acetone. Systemic weight loss for type 1 or weight gain for type 2. Respiratory, for type 1, most of all, it is Kussmaul breathing with hyperventilation. Gastric GI symptomatic, that is typical for type 1 too. Mostly it is nausea, vomiting, and abdominal pain. And urinary symptoms like polyuria and glucoseuria, they are possible and they are specific for both types of diabetes. Okay, and let's discuss a little bit complications, because you know that diabetes kill per year a huge number of people in all world, in all countries, but most of them people have high mortality, high morbidity, hospitalizations, cardiovascular events, not due to specifically hyperglycemia, but due to different complications of this hyperglycemia. And all complications we can divide on acute and chronic. Acute complication, it is severe hyperglycemic states and diabetic comas. And first, most usual for type 1 diabetes, it is diabetic ketoacidosis. It is potentially life-threatening complication, happens in patients with diabetes mellitus type 1. It can occur in those with diabetes mellitus type 2, much more rare, but you should know that it's possible. The symptoms usually involve over a period of about 24 hours. Predominant symptoms are nausea and vomiting, pronounced thirst, excessive urine production, and abdominal pain. Breathing becomes labored of a deep, gasping character. We name it Kussmaul respiration. It looks like this. In severe cases, there may be confusion, lethargy, stupor, and coma. On physical exam, there is an evidence of dehydration that usually goes with tachycardia and low blood pressure. It is ketotic odor. It's what I told you, very specific, like bad apples, fruity, sweety odor. And it can lead, unfortunately, to death. Blood analysis will reveal significant decrease in pH because it is acidosis, ketonic bodies, ketones are increased acidity. That's why it leads to severe acidosis, systemic acidosis in patient. pH will be lower than 7.3. Urine analysis will reveal significant levels of ketone bodies, often before over symptoms. Okay, it was ketoacidosis. We have another severe hyperglycemic state that can lead to diabetic coma, but without ketonic bodies, that are caused not by acidosis. The severity caused not by acidosis, and here severity caused by very huge hyperglycemia and increased osmolarity of plasma. We name this situation like non-ketotic hyperosmolar state. An acute complication sharing many symptoms with diabetic ketoacidosis but entirely different origin. Understandable why it more typical for type 2 diabetes mellitus, because here patients in most cases are not able to produce ketonic acids, and this situation even more severe than ketoacidosis. Water osmotically drawn out of the cells into the blood. The kidneys eventually begin to dump glucose into the urine. Serum pH will be more than 7.3, usually normal. Bicarbonates more than 15 milliequal per liter, and small ketone urea and absent to low ketone amia, less than 3 millimoles per liter. Here will be increased risk of blood clot formation. If fluid is not replaced, the osmotic effect of high glucose level combined with the loss of water will eventually lead to dehydration. Some alteration in conscious lethargy may ultimately progress to a coma. If patient with this non-ketotic hyperosmolarity go to the coma, mortality is very high, and in all countries it's really huge. 70-80% of all patients who go to hyperosmolar coma, we can't return it at all. Okay, coma. A life-threatening diabetes mellitus complication that caused unconsciousness. It can be three different main types. Severe low blood sugar in diabetes mellitus person that we name hypoglycemic coma. It is the most dangerous one. Diabetic ketoacidosis, what we discuss, advanced enough to result in unconsciousness from combination of severely increased blood sugar level, dehydration and shock and exhaustion. And hyperosmolar non-ketotic coma, in which an extremely high blood sugar level and dehydration alone are sufficient to cause unconsciousness. That's why we have three main situations with diabetic coma. First, two of them with hyperglycemia, both situations we discuss, it is a ketoacidosis and hyperosmolar non-ketotic state, and third one, it is hypoglycemic coma when low level of glycemia extremely low. It's possible one more very specific type. Fortunately, it is very rare, but it is very severe. It is, we name it lactacidotic coma. Who want five, who interested in topic, you can read what is that. In general, diabetic coma was a diagnostic problem before the late 1970s, when glucose meters and rapid blood chemistry analyzers become universally available in hospital. From those times, this problem become much more lower, but the risk is still enough high. Okay, about ketoacidosis and hyperosmolar non-ketotic states we talked a little bit. What about hypoglycemia? I told you that it is the most danger because it is the most rapid, and even in a short period it can lead to coma and even death. Hypoglycemia, it is medical emergency that involves an abnormality, diminished content of glucose in the blood. Symptoms of hypoglycemia usually do not occur until glycemia level is 2.8 to 3 millimoles per liter. But here present a very important moment. For example, a patient after persistent hyperglycemic state, or for example after hyperglycemic coma with a very high level, constant high level of glycemia. If we decrease level of glycemia too rapidly, for example till normal, it is 5.5, yes, but if it caused medically and in a very short period, clinically patient will feel symptoms of hypoglycemia. That's why when you will learn on fourth year treatment of diabetes and diabetic complications, please pay attention that management of hyperglycemic states have to be very careful, soft and prolonged by the time, not to lead to hypoglycemia due to rapid decreasement of it. Okay, manifestation, clinical symptoms, they looks like adrenergic manifestation. Yes, most often of them it is shakiness, anxiety, nervousness, palpitations, tachycardia, sweating, pallor, coldness, clamminess, and mydriasis. You look like they like opposite from hyperglycemia. We can see glucagon manifestation because on low glucose it will be stimulation of glucagon effects. It is hunger, nausea, vomiting, abdominal discomfort, and possible headaches. Neuroglycopenic manifestation. It is abnormal thinking, depression, crying, exaggerated concerns, paresthesia, negativism, emotional lability, fatigue, weakness, apathy, lethargy, daydreaming, confusion, amnesia, blurred vision, automatic behavior, difficulty speaking, incoordination, motor deficit, paresthesia, headache, stupor, coma, etc. You see how a lot different neurological and psychological manifestation, and they really manifest in a very short period. And if person spontaneously become very active, very emotional, and even aggressive, feel a very spontaneous hunger, first of all, we always do about hypoglycemia for this person. Even if we don't have possibility in this moment, rapid moment, to check glycemia level, first management it is to give something sweetie to conchiconate patient, and for unconchiconate inject IV glucose, even if you are not sure that it is hypoglycemia, because situation is really dangerous. Okay, and chronic complications. We don't have enough time today for it. That's why I just name and several words about them. But at home, please read what is that. All of them connected with damaging of vessels and damaging of nerves. Damaging of nerves we named diabetic neuropathy. And damaging of vessels we can divide on damaging of big vessels and small vessels, and we name it relatively microvascular complications of diabetes and macrovascular complications of diabetes. When we talk about microvascular, we mean diabetic cardiomyopathy, diabetic nephropathy, diabetic neuropathy, because damaging of all vessels of nerves, it is one of the mechanisms of neuropathy. Moreover, it is diabetic retinopathy and encephalopathy. Macrovascular with damaging of big arteries, it is coronary artery disease, diabetic myonecrosis, peripheral vascular disease, and stroke. Other complications, but they can be, but through the previous mechanism by damaging of vessels and nerves. It is GI manifestation with gastroparesis and diarrhea. It can be genitourinary symptoms with uropathy and sexual dysfunction. It can be dermatological manifestations, different infections, cataracts, glaucoma, and periodontal disease. It is a most often really big number of different disorders in all organs, in all systems, can be complications of diabetes mellitus. And the most often and unfortunately the same most danger complications, yes, and most often causes of hospitalization and medical activity. Diabetes lead to such a big problems with such complications like blindness, heart attacks, amputations, and kidney failure. It is the most danger and unfortunately very, very often results of course of diabetes mellitus. What is diabetic retinopathy? It results in a scattered hemorrhages, yellow exudates, and neovascularization. It is one of the most often causes of blindness due to diabetes. This patient has neovascular vessels proliferating from the optic disc, requiring urgent pan-retinal laser photocoagulation. Okay, and let's return a little bit to hypoglycemia because this part is very important. Low blood sugar is common in patients with diabetes mellitus. Most cases are mild and not considered a medical emergencies. Effects can range from feelings of unease, sweating, trembling, we discuss it, and increased appetite in mild cases, to more serious tissues such as confusion, aggressiveness, seizures, unconsciousness, and rarely permanent brain damage or death in severe cases. And schematically for you, because every person, every doctor, and even medical students can meet in with a high-risk person in state of hypoglycemia, and it is a situation when it really you have minutes to diagnose and to do something. That's why one more time schematically I want to stop on symptoms of hypoglycemia. If you see these symptoms in somebody's at street, somebody's in university, from your friends, from other people you don't know at all, if you see this complex of symptoms, you think first of all about hypoglycemia, and if it's possible you should detailize if this person have diabetes or no, and even if you don't know, you should do some first emergency help with giving of something sweetie or drink or food, or if patient is unconscious or confused, it is IV glucose. If you don't really know is this hypoglycemia. One more time, this complex of symptoms: it is shaking, it is sweating, it is anxious, it is dizziness, hunger, fast heartbeat, impaired vision, weakness, fatigue, headache, and irritable. That started during short period. It can be 10, 15, 20 minutes, not longer. If you see such person, you have to do something and at least suspect hypoglycemia in diabetic patient. Okay, for today that's all. It is a little bit chaotic because the material is really huge. Please read at home, and as usual, if you have questions, you have comments, or I not include in this lecture some interesting for you information, your comments and question you can write here in comments under the video, at our closed Facebook page under the lecture, and as usual I ask you to leave in comments under the video name and group of every student who listen my lecture. For today that's all. I'm waiting for your activity, and goodbye.